Okay, well, I think we can begin with the introductions and welcomes, and I'll just keep letting people in as they come. So yes, welcome to everybody today for joining our sessions. You will notice that I've clicked record, so yeah, today's session is being recorded. I'm going to keep getting distracted by letting people into the session, but what we thought we'd do, we thought we'd go through the presentation and then leave room at the end for questions. And please feel free at the end to ask your questions verbally or put them into the chat. So what our session is looking at today is addressing the emotional well-being of personnel working with children with cancer in low to middle income countries and experiences from Soleterre and World Child Cancer in both Cameroon and Uganda and Sub-Saharan Africa more widely. So I'm just going to ask each of the presenters to just briefly introduce themselves before I go through the outline of today's presentation. So Alessandra, can I just pass over to you first to introduce yourself?
Thanks, Megan. I'm Alessandra Ravelli. I'm the Global Health Coordinator for Soleterre. I'm partially replacing our president, Damiano Rizzi, who is a psychologist who was supposed to present a part of the slides, but he sends his apologies. He had an emergency.
Great, thank you, Alessandra. Joyce, can I come to you next, please?
Yes, thank you. Good morning and good afternoon. In Uganda, it's a good afternoon. I am Joyce, a consultant at Soleterre at Rainbow Family Home. I provide psychological counseling to the staff working with children diagnosed with cancer. I'll be one of the presenters today. Thank you.
Thank you, Joyce. Vera?
I am Vera Lafi-Samba. I am a nurse. I work in pediatric oncology at Mbopi Baptist Hospital, Douala. I'm glad to be here.
Thank you, Vera. Ashraf?
Hello, everyone. I'm Ashraf Iga from Uganda, working with Uganda Cancer Institute in the Department of Pediatric Oncology. I'm glad to be here.
Thank you, Ashraf. And I'm Megan Cruz. I'm the Psychosocial Support Advisor at World Child Cancer. So welcome to you all. Thank you for joining us today. Just to give you an outline of the session today. So firstly, we'll give you an overview of this new alliance that we have between Soleterre and World Child Cancer. We will then look at go through some work-related stress in health personnel working within pediatric oncology patients. Then 3 of us will do a presentation about addressing the emotional well-being of nurses working in pediatric oncology in low to middle income countries. And then finally, Soleterre will look at the psychological support to personnel working with children with cancer in North Uganda. I'm just going to stop there because I can see some other people are trying to get in, so I will just admit them. There we go. Okay. Okay, so over to Alessandra first.
Thanks. So the reason why we are presenting today is that earlier this year, Soleterre and World Child Cancer decided to create a new alliance to jointly fight child cancer in Africa. We did this because we see many commonalities. We have common strategic directions, some geographic and technical complementarity. Our common goal is ensuring that more children with cancer in low and middle income countries have timely access to quality treatment. And we both wanted to have a higher impact with our interventions, thus contributing to WHO Global Initiative for Childhood Cancer. So I'll give you a bit of a background on why we are going to talk about health personnel work-related stress. So it is widely documented in scientific literature that health personnel have a high impact of work-related stress, and this adds to compassion fatigue, which is a gradual decrease over time in the wish to provide care and exercise compassion. And this is often a common feature among health personnel, also defined the cost of care syndrome. For instance, a survey in 2009 identified the different incidents of stress and compassion fatigue in different specializations. And for instance, emergency response nurses were identified as having a very high incidence, 85%. Oops, you skipped, yes. So both the medical and non-medical staff who are working with children with cancer and their caregivers are constantly exposed to compassion fatigue and work-related stress. They are constantly exposed to death and pain, moral and ethical dilemmas regarding treatment decision, and they often need to communicate difficult information and decisions. Plus, there is staff shortage, high workloads, and complex and intense treatments. So they can develop compassion fatigue, which in turn can develop into secondary traumatic stress, where the personnel loses perspective on hazards and benefits they may, and this may lead to avoid situations that we call traumatic events, such as the loss of a patient. And further stages can lead to burnout and total loss of interest towards the persons that should receive attention and care. And this often leads to depersonalization. So there is a precarious balance between professional satisfaction and compassion fatigue, and thus it's important to monitor the latter in order to prevent secondary traumatic stress and burnout. So there are several studies that look into these aspects. For instance, the one from Rushton in 2015 showed that moral distress is a significant predictor of all three aspects of burnout. And there is a strong association between burnout and resilience. So greater resilience protects nurses from emotional exhaustion and contributes to personal accomplishment. As well, spiritual well-being and is reducing emotional exhaustion and depersonalization. Physical well-being was associated with personal accomplishment, and meaning in patient care and hope were independent predictors of burnout. So high levels of resilience were associated with increased hope and reduced stress. A similar study in South Africa in 2019 revealed that oncology nurses are affected emotionally in caring with their patients, and this makes them prone to compassion fatigue. So the recommendation of this study was on acknowledging this fact and supporting the nurses to set reflection on how they are managing the stressors they encounter in daily work.
Great, thank you, Alessandra. So each of us now, I'll give an overview of the work of World Child Cancer and go into our presentation, and then I'll pass back to Alessandra to do the same for Soleterre. So very, very briefly to give you an overview of the work of World Child Cancer. So we have four main strands to our work. First one being early diagnosis. So we recognise that we need to increase the number of children who are receiving an early diagnosis. So we do a lot of work around the early warning signs and symptoms of childhood cancer. Improving treatment. So this is mainly done through our twinning and our training work. And we're always looking at ways that we can improve the availability of high quality treatment and care. Family support. So this is our psychosocial part of our work. So we provide financial support to families, but we also try and increase the emotional and practical support available to families, trying to improve their quality of life and well-being. And one element of that work is looking at how we can improve the support available to healthcare staff, which is what this presentation is about today. And then finally, our advocacy work, so raising awareness of childhood cancer and the needs of the families that we are working with. So our presentation, this part of the presentation is around addressing the well-being of nurses working within paediatric in countries in low to middle income countries. And I'll be delivering this with Vera and Shiraf. So we're going to introduce you to the work of the Nurses Wellbeing Group. We will look at some results from a recent survey that we conducted, and I will also be telling you briefly about a pilot that we're soon going to be implementing. So as Alessandra has already mentioned, there is evidence to show that nurses working within paediatric oncology have this heightened exposure to death and dying and pain and suffering, and also higher rates of treatment abandonment rates. And all of this has a really big impact on the nurses working in these countries. And we know that there is little, if any, support available to these nurses. So in February 2020, we decided to set up a group which we called the Nurses Wellbeing Group. And the aim of our group is to try and explore ways that the well-being of nurses working in paediatric oncology can be supported. The key objectives of our group are to identify and increase support available to nurses working in paediatric oncology. And this might be through emotional support, peer support, and also raising awareness amongst the management and staff of the importance of supporting this group of nurses. Our wellbeing group is represented by 7 countries, and they are Cameroon, Uganda, Ghana, Tanzania, Botswana, Nigeria, and Zambia. And we've got 13 nurses in our group, along with myself.
So in December 2020, the Nurses Wellbeing Group conducted a survey to collect the views of a convenient sample of nurses working in pediatric oncology, specifically in sub-Saharan Africa. The survey consisted of 2 parts. Part 1, strategies nurses currently use to manage their emotional well-being and to build their resilience in the workplace. Part 2, improving and increasing the provision of emotional well-being support. So members of the Nurses Wellbeing Group saturated the survey to other nurses working within the pediatric oncology via WhatsApp groups, emails, and open oral invitations. We used the Survey Monkey to saturate the survey amongst the nurses within the Sub-Saharan Africa, and the survey was available both in English and French. So this the total of 64 surveys were completed amongst 11 Sub-Saharan Africa, and these included Zimbabwe, South Africa, Ghana, Tanzania, Nigeria, Zambia, Cameroon, Lesotho, Botswana, and Malawi.
So the nurses were asked, what impact of their work have an emotional impact on you? There were a number of responses, but here we highlight the top 3 responses. The first one, which many of them highlighted, was witnessing children in pain and suffering. The second, death of a child. And the last one, caring for children at the end of life. And these are the day-to-day things that the nurses in pediatric oncology go through. And again, when they were asked how they manage these heightened emotions, respondents reported using a number of methods for managing their emotional well-being and for building their resilience. The top 3 responses among the rest that they gave, as we see on the bar chart, were they discussed with a colleague, up to 88% of them, and then some of them talked about thinking positively. And again, 81%, another 81% still said their faith, religion, and spirituality helps them a lot, to respond to heightened emotions. And in terms of support, which they get when they have these heightened emotions, 83% of respondents stated that they were not provided with sufficient support with their emotional well-being at work. And the 3 main challenges highlighted by respondents when it comes to accessing support for their emotional well-being were lack of formal structures, or even whether formal or informal, there's no availability of emotional support. Then there's high workload, and so no time for support. And they have leadership and management challenges. Leadership does not understand the impact of pediatric oncology and does not know maybe how to support them, even when they try to understand. And with this, the survey highlighted 4 main areas where support is currently deficient and the interventions that could be established to address these gaps. So if there is access to a psychologist, this intervention will really be great. The second one is having case study meetings to discuss the emotional impact of the work. The third is getting more support and recognition from management with emotional well-being and the impact of work. And lastly, having more training in emotional well-being and resilience among staff who work in pediatric oncology. With this, I would like to share a personal reflection. The childhood cancer work in my hospital started managing only bucket lymphoma, and I was selected to work in that unit. I loved to work with the families. I enjoyed the work with the children. But each time you treat the child, they responded so well, and then they relapse and you find them dying. And so I had this feeling in me, run away each time. And as time went on, with the help of the World Child Cancer, many more childhood cancer types were added. And so the workload increased. And that meant we saw many more children in pain, different types of cancer, and more complex treatments. And the painful side is some children get to the healthcare service at stage 1. And depending on the center where they go, nobody thinks about cancer. And so they move from one health unit to another, and they end up coming to the childhood cancer center late, maybe in stage 4, just for us to talk about palliative care and manage them, manage their symptoms and the end of life care. And this is very distressing. And it doesn't occur once, it is day in, day out. You see this kind of children who turn round and round and come to the treatment center late. Not because the parents did not take them for care early, but because the healthcare workers did not think about cancer. And so this heightens the emotion or that feeling of runaway. And in December 2020, the World Child Cancer organized a psychosocial support training of trainers workshop. And in this workshop, this hidden idea of runaway that I had in me and I was not sharing, we expressed ourselves, and I noticed that I was not the only one who had this feeling, but my fellow colleagues also had that feeling. And so we were able to share, and sharing, when children undergo pain, supporting one another. Maybe somebody is feeling so bad, a new nurse in oncology, we try to discuss. And when a child dies, we don't only look at the negative, because formally we will say we wasted our time, but we will look at the positive influence that we have, helping the child to have a diagnosis, showing that child love and some concern, relieving their symptoms at the end of life. We celebrate the positive aspects of work that we do. We encourage ourselves, we support the family, and we feel good that we are able to contribute to the life of these children. This kind of reflection has helped us, to go forward and not to feel like we will run away. And I remember even this morning when I was talking with one of my colleagues, she said, we are not going to run, we will remain in it and we will continue the fight against childhood cancer. So it is not yet over. We have still many challenges, but we know how to support ourselves and we continue to move forward and increase our resilience. With that, I hand over to Ashraf to share his own personal reflection.
Okay, thank you, Vela. About my personal reflection, I personally have had lots of terrible and saddening memories, but the major one was during the last year, during the COVID-19 pandemic. Here comes a 7-year-old girl newly diagnosed with acute myeloid leukemia with supportive parents, and the treatment was initiated immediately. So we had hope, especially me, that she's going to get better. Unfortunately, during the course of treatment, the father contacted COVID-19, and which he spread to the girl. They had to be taken to the isolation unit. But during this time, everyone was green about COVID-19 management, specifically in cancer patients. This led to inconsistency in her treatment. When she tested negative, she was brought back to our unit, but unfortunately, after repeat bone marrow biopsy, it was declared to us that she's now under palliative care due to time loss. Few weeks later, she passed on. It tortured me emotionally for months because I had that mutual attachment with that young girl. Unfortunately, I had to deal with it individually, in that I had to ask for some day offs where I had to travel and visit my family, friends. And by the time I came back, my mind had freshened up slightly, but still I could get some memories day by day. Till now, it still hurts me. If at all we had a clinical psychologist whom we can immediately talk to for help in case we get some emotional challenges, it would be better. Back to you, Megan.
Thank you both of you for sharing your personal reflection. I think for me, it's very clear to see from these personal reflections and from the results of the survey that the Nurses Wellbeing Group did that more needs to be done to support nurses working within paediatric oncology. So as a result of the survey and of the needs of the nurses, we, World Child Cancer and the Nurses Wellbeing Group are about to implement a pilot. We've recruited a clinical psychologist in Ghana, and he will be providing support and mentoring to nurses working in paediatric oncology across the whole of sub-Saharan Africa. The pilot's made up of 2 parts. So firstly, it will be 2 face-to-face sessions each month for nurses working at Kolobu Teaching Hospital in Accra, and then 2 online sessions for nurses working at Kolobu, but also Confinautry Teaching Hospital in Kumasi and the 3 other shared care centres across Ghana. The second part of the pilot will be offering remote support to nurses across sub-Saharan Africa, and this will be made up of 4 online sessions per month. The pilot's due to start literally in a couple of weeks on the 1st of December, and it will last for 9 months. And what we're really hoping is that this pilot will provide us with further evidence of the need to support nurses and the impact this kind of support can have on nurses. And just to say also that this pilot is just a starting point. World Child Cancer and the Nurses Wellbeing Group, we're keen to do more work looking at how we can support nurses more in the future. So just to summarise our section of the presentation, we've introduced you to the Nurses Wellbeing Group and looked at some results from the survey that we did. And we've also described the pilot, which will be starting in a couple of weeks. If anyone would like any more information on the work of the Nurses Wellbeing Group, then please feel free to email me at megan.cruz@worldchildcancer.org. Okay, so now I'm going to pass over to Alessandra and to Joyce. But can I just take a moment here just to remind everyone to mute themselves, please?
Thank you, Megan. So I will briefly give you a snapshot of what Soleterre is doing. So Soleterre is figures in the slide are a bit outdated, but we have a project called Great Against Cancer, supporting pediatric oncology in Italy and in some countries. In fact, there is now an additional country that is Burkina Faso, in addition to the ones you see on the map. And we also intervene in different areas, but our main focus is on the psychosocial support and providing free of cost accommodation and services to children and their caregivers as they go through the treatment, diagnosis and treatment path for cancer. So we'll soon have actually 6 houses instead of 3. There will be additional ones in Burkina Faso, Morocco, and one in Italy. And but yeah, the supportive, the psychological support is something that is across all the different projects. Next slide, please, Megan. So what we are going to talk about today is the project that we have in Uganda, northern Uganda, where Soleterre is providing psychological support to personnel working with children with cancer. And when I say personnel, it's both medical and non-medical. So as I said, we are providing psychological support to children under cancer treatment and their caregivers. We started in Italy and Ukraine, and that's been going on for more than a decade. So based on the experience we developed in Ukraine, we also introduced the psychological support in the other countries where we run family homes. So we support the children under cancer treatment and their caregivers, both when they are staying in the family home or they are staying in the hospital. And psychological support, we know it's key for children and caregivers as they face the difficult path, but it's also essential for the personnel, both the medical and paramedical social workers, who in their daily routine face several stressors deriving from their regular work and interaction with children and caregivers. So there are very high levels of stress in medical and non-medical staff working with children, and still not all of the personnel are accessing or requesting the psychological support. We have seen that the reasons for these are multiple and vary according to context and other factors, but we've seen in our experience that some of the reasons are not the immediate understanding of what the benefits would be, or the fact that they are facing difficulties making time because of their high workloads. And in some cases also there is some persisting stigma associated with mental health needs. So in the first 2 countries where we provided this service, it took time to our psychologists to involve medical and non-medical staff, both in individual and group supports. But in the end, we've seen good results and great appreciation. So in the next slide, I have a quote from one of the psychologists who are working with Soleterre in the pediatric oncology unit of San Matteo Hospital. He says, "We recognize fatigue, pain, and rage as physiological and intrinsic elements in the relationship between children and medical and non-medical staff in the oncology unit. And these are neither mistakes nor obstacles on our path, but they are so instead folds of our soul. If recognized, and I would add from myself, if helped to be dealt with, they make us stronger and more self-conscious. So I will finally reach the point where I tell you about our project in North Uganda. We are running the Rainbow Family Home, which is inside the St. Mary's Lacho Hospital in Gulu. The children who are under treatment at Lacho are hosted in the family home, and they have access to a range of services. We have also introduced a consultant psychologist who is providing support to the staff working in the family home and to the Lacho's medical and non-medical staff working in the pediatric oncology ward. The psychologist who is going to be the next to tell you about her experience is Joyce, and she started by assessing the individual needs and perceptions through a questionnaire before she involved the staff in individual and group sessions. Over to you, Dr. Joyce.
Yes, thank you so much, Alessandra. Yeah, we conducted a psychological needs for the health personnel working with the children diagnosed by cancer. We use questionnaires to ask this personnel to make them self-evaluate in the several aspects of their work, personal feeling or feeling related to perception of their job performance, what their roles are, the level of their exhaustion, how emotional drain they feel, and then their relationship with the caregivers, colleagues, supervisors, and the patients. In the assessment that we conducted, majority of the staff responded that they feel exhausted and that they face work-related stress. They shared that they understand what their roles and responsibilities are clearly. However, they feel that the workload is not manageable. And yet in our assessment, we realized that they were able to accomplish their task within schedule. Majority of the staff reported being emotionally drained. They shared they lack creativity and concentration. And yet again, for majority of their work performance was good. So what is the impact of the psychological support? After more than 2 years of provision of this support, which was conducted either individually or as group, Soleterre and the psychologist decided to conduct a qualitative evaluation to check on the impact of the service of the psychologist being rendered to the staff. It was the same assessment tool we used as baseline, and then also we adapted it through additional questions, which allowed respondents to provide examples to support their self-evaluation, and then as they reflect on improvement and other issues or challenges that had remained unsolved. So what we did, we asked this staff to self-administer these questionnaires with support of Rainbow Family Home psychologists, who then provide explanations, the purpose and the method of the survey. In total, we are able to conduct survey for 6 staff of the Rainbow Family Home, and then 3 staff of the hospital who responded to the survey. So this evaluation were highly scarce. 1, they shared that there's increased capacity for them to communicate with colleagues and supervisors. Also, we noted that there's increased efficiency and capacity to deal with complex situations, and also better understanding of self-care for the staff, and then their high emotional strength. Majority of the response also scored highest on this, that they now better understand what compassion fatigue is and how to deal with it, and then so that they had increased capacity to develop at least a self-care plan that they can use as they face day-to-day stress as they work with the children. So the following were the responses that were described as the key changes they notice in their work. The respondents say that in their working with children who are diagnosed with cancer, they now understand better what these children go through. They're also better able to deal with the different stress that comes with working with the person who are suffering, like compassion stress. They also understood that the more they attach themselves to these children, the more they suffer emotional pain. So in a way, much as they were working for these children, they said, we better understand that maybe the less attachment, the better. And then that the pain and emotion that they experience has been replaced by a calmer interaction. Much as the children are suffering, they are able to control, contain their own emotion and interact in a calm manner with these children. The respondents in their working with the caregivers, they say they better understand how to interact with the caregivers. They also have better tools that they know they use to help them. And then that they also attain skills in communicating with the caregivers, and they're able to adapt the different approaches, how to respond to the different personalities, the caregivers. And also the relationship with the doctors and nurses, especially for the Rainbow Family Home. They have better interaction. There's no longer emotional distance. They feel free to access the ward and visit the children. Previously, many of them were shying away from visiting these children simply because they felt that they would not be able to bear the emotional distress that comes with seeing children who are suffering. And then they're also better able to define boundaries. What do I need to do? Where do I start? Where do I work? How do I take care of myself? What do I need to do not to mix work and then personal life? And that they felt more confident and they have better interaction. And then with their personal family life, as I said, they have better balance, don't mix work and personal life. They understand better how they are, who they are, and then they're able to share with colleagues better. So all in all, this is our conclusion, that all Rainbow Family Home LHO staff who accessed the service and responded to the survey, they highly rated the positive impact from the support that the psychologist was rendering to them in terms of prevention of burnout, compassion fatigue as they work with the suffering individuals, and how to cope with emotions and painful situations that arise out of their work, and then gaining better communication skills in their work. And then that they understand the role of the psychologist and the importance of psychological support, that it helps them deal with difficult situations. However, some of the staff do not access this support or the service. The reason might be due to lack of time, or some of them doubt the worth of accessing the service, or other reasons. I have a valid suggestion from a doctor receiving psychological support provided by Soleterre in Matteo Hospital in Italy, recommended that this type of intervention has to have a buy-in of the hospital leaderships, of the leaders in the hospital on the ward, in order for the medical staff or the non-medical workers to make time really to access these services. The chief of the ward has to understand and then be able to convey to their team the importance of psychological support, so that also the staff may have a buy-in and receive this service to enable them really work with the children as they provide quality services. Thank you. Back to you, Alessandra.
Thanks. I think, yeah, this is a picture of the family home. I think it's a session with the caregivers. And I think now we can open to questions.
Please feel free, anyone, to ask any questions. I'll just look through the chat as well to see if there are any questions there.
I don't mind kickstarting. I'm not a specialist at all, so sorry if it's not relevant. But we're starting to work with play therapists. I mean, we already work with a play therapist, for instance, in Ghana. And I just wondered if, for instance, the play therapists trained the nurses to giving them tools to make it more manageable, to manage the pain of children during procedures and stuff like that. Could it actually then also help the nurses in turn, because they feel more empowered and equipped to help the children manage that pain and suffering? And but sorry, again, I'm really not qualified to just answer. Sorry if it's irrelevant.
It's certainly not irrelevant, Domitille, at all. I don't know. I want to pass that question to Vera if I can. But just before I pass over to Vera, one thing we do in the training that we deliver that Vera was talking about at the beginning of her presentation is we do train nurses in some sort of simple play therapy techniques and distraction therapy. And Vera's been a part of that training. So Vera, I just wonder if you want to say something about how, if you do feel that having those skills has empowered you in your work. Can you unmute yourself first?
Yeah. So it is important for the nurses to have the skills in distracting children during painful procedures. I think the play therapists, I talked with her. From what I saw, I think that she's distracting the children, it is helping, and the nurses are getting it too. But personally, we don't have a play therapist here. I've used it more after the psychosocial support training of trainers, and it is very helpful. You discover that by the time the children are discovering themselves, you are really deep into the procedure or you are almost done. And it's really useful. So I think every nurse needs to have an idea of it. And the psychosocial support training highlights it, which I think at the end, each nurse will be able to use it. When I interacted with the nurses in Ghana, I don't know when this is here, I feel that the play therapist, has involved them in distraction technique. I don't know if anybody from Ghana will want to
we actually,
that.
We have our child life specialist from Ghana on the call, but I don't necessarily want to put her on the spot. Augusta is with us today.
Hello, everyone.
Hi, Wendy.
I'm Wendy from Ghana, a pediatric oncology nurse. Yes, so to add up to what Vera said, we do have Augusta on board as well. So she's present most of the times in the procedure room to offer her services, and she distracts them as much as possible. So we do pick up from there and learn some things or some techniques she uses, and also adapt and use them when she's not around. So that training also helps us in one way or the other. Thank you.
Thank you, Wendy. Ashraf, you have your hand up. Would you like to add something?
Yes, Megan, to supplement on that, actually here in Uganda, we're a bit fortunate that in our department, we have a gazetted area for specifically playroom for children, and it has really helped them emotionally regarding pain management, whereby during the daytime, if at all it's not day treatment time, they go and try to pass time from there. So it has really worked, like as she has said. Thank you. Back to you, Megan.
Thank you, Ashraf. I can see we have another question here. It's from Piera. According to your experience, what is the doctor's attitude towards this topic? Are they also using psychological services where available, or do they have separate dedicated ones? Alessandra, do you want, I know you had something on this in your presentation and your experience of doctors accessing this kind of support.
I can let Joyce try to answer first, and then if there's anything to add.
Yes, thank you so much. I would say that maybe not all, but I would say at least 3/4 are interested in this kind of services. However, with our experience, we find that they really don't have time. Because it's like whenever we make appointment, someone can call you, make appointment, but then the person fails to honor the appointment. You make a follow-up, say, oh, I was so busy at such a time. So you realize that at times they really don't have time. I imagine maybe they are overwhelmed, and because they are so much into seeing that these children are supported in all ways, to the point that one cannot also think about self-care. That's what I can say at the moment. Thank you.
Yeah, I can maybe add that, yes, there is no separate service, but the idea is that, for instance, we were talking about it with Joyce, if the leadership decides that there are some moments where all the team is involved in learning, learning time for other different topics, we can take advantage of this slot, let's call it, which is in which the psychologist is invited and can have the group session. And then for individual sessions, then there can be more flexibility in terms of to match the time needs and schedule of doctors or also nurses in case.
Oh, sorry, can someone mute themselves? Just on the back of that question, I'd be interested to ask a question to any of the nurses on the call who would like to answer. With group supports from a psychologist, do you feel it would be different if doctors were with you as nurses in your group supervision? Would you prefer it if nurses were offered clinical psychology separately from the doctors, or is that not an issue?
Can I answer that?
Please go ahead, Joyce.
Thank you, thank you. Yeah, my own perception, to me, it would be a yes and a no. A yes, to me, it would be very beneficial for the nurses and the doctors to receive as a group this kind of services, because then they'll be able to share experiences, give support to one another. And then maybe the nurse would also say, okay, if also a doctor has this kind of emotional distress, then I'm not exceptional. On the other side, I would feel that putting together the nurses and the doctors together in group session, maybe for certain reasons, other doctors or other nurses might shy away, especially if you have a supervisor who's also in the group. And then if you are sharing personal challenges, work-related, supervisor-supervisee relationship, maybe it would deter them and they won't be able to open up. But depends on maybe assessment and how we find what is convenient for them. Of course, normally what we do whenever we bring in people in group, we first ask their view. Do you feel this works? However, when we see that someone supervises some other person, then it becomes very challenging to bring the person being supervised and the supervisor in the same group. Thank you.
Thank you, Joyce. That's really, really insightful and really interesting. Thank you. Wendy's asked you a question, Joyce, please. How long are the individual sessions with nurses?
The question sounds general, but normally, given the busy schedule of our nurses, we make appointment and see them every fortnight. We can't see them weekly because they are very busy. However, we also give room for any individual needs that arises during the days or during the week, even when they are not scheduled. They are free to call the psychologist and have a one-on-one, either through telecounseling or face-to-face. Yeah, but ideally weekly would do, but then given the schedule, the busy schedule, they can't make it weekly, at least fortnightly. Thank you.
Thank you, Joyce. Do we have any other questions? We have 5 minutes remaining, so please take the time if you have a question.
I think John has. Yeah.
John, sorry, I didn't see your hand raised. Please go ahead.
Hi, it's not so much a question really as a comment. I just wanted to say, well, two things really. Firstly, to say how pleased I am at the partnership we're developing between World Child Cancer and Soleterre. I think it's really, really productive, and this session has shown that. And I hope it'll go from strength to strength. So that's the first thing. And the second thing is just how this session has brought home to me once again just how awesome the nurses are in childhood cancer, for what they deal with day after day, and the stress that they absorb in doing it. And I think if we between us can help them to deal with that more effectively, that's just such a good thing for us to do. So thank you all for the work that you do.
Thank you, John. Just to follow up on from that, actually, Ella, who's one of the nurses in the wellbeing group, who's from Nigeria, she did a very similar presentation about our work at the Nurses Wellbeing Group at the SIOP conference. And it was interesting because one thing she said is that you can't overinvest in nurses. And you train one nurse, and the impact that has on families and the children is huge. And I thought that was a really powerful statement that she said. So yeah, I agree with you, John. The nurses do an incredible job. Great. So, well, if we've got no other questions, then just on behalf of all the presenters, just like to say thank you very much for joining, and please do feel free to follow up with any of us if you have any further questions.
Thanks a lot, everyone, and also from Soleterre. And John, definitely we're also very happy of this alliance, and we are looking forward to more initiatives of this type, and also more on the ground as well.
All right, I think we'll say goodbye now.
Thank you. Bye-bye.
Thank you.
Bye.
Bye-bye. Thank you for joining.
Bye.